Welcome to the Health Channel, all health all the time. I'm Olga Villaverde, coming to you from the Baptist Health South Florida studios. Aneurysms can happen anywhere in our arteries due to damage caused by a number of factors. Untreated aneurysms can lead to blood clots or ruptures that require serious intervention. So today, we're going to help you understand your risk and get a look at the latest treatments available. And here to talk about all of this is Dr. Juan Pereda, a vascular surgeon at the Miami Cardiac and Vascular Institute. Welcome, doctor.
Hello, Olga. How are you?
I'm doing fantastic, and you?
Very well, thank you.
I know this is the first time on the show.
Yes, it's a pleasure to be here.
We are pleased to have you. Thank you for your time. We do appreciate it. We know how busy you are. First, let's talk about what you do. You're a vascular surgeon. So for our viewers, tell us what that entails. And I know it takes a long time to become a vascular surgeon because my father is one. So it's not just your ordinary, just pre-med and med school. It's many, many years.
Yes, correct. The training for vascular surgery is quite long and arduous.
Yes, it is.
In the days when I trained, general surgery was a requirement before you became a vascular surgeon. So it was an offshoot of general surgery. Nowadays, the younger generation, some of them can go into vascular surgery right out of medical school. That began somewhere in the early 2000s. But yeah, it's 7 to 9 years of training after medical school.
It's a long time, I know. And my father always had a passion for it, just loved everything about vascular, which obviously has to do with our veins, our arteries, capillaries. What's your passion for it?
Vascular surgery, initially when I picked it, it was quantitative and it made sense to me. Blood flow is as simple and as complicated as it sounds. Mm-hmm. Getting blood to parts of the body where it needs to be. And so it's sort of like plumbing of the body. Mm-hmm. And so it involves blood getting there through the arteries and coming back to the veins. And operating on blood vessels is challenging, and that's part of what attracted me to it.
And I love hearing that plumbing, because that's what I heard a lot with my father. Well, the plumbing's not good here, and I'd be like, oh, we got to fix it. He's like, yes, we do.
That's right.
What kind of patients are you working with on a daily basis?
We treat arterial disease, which the topic of today is aneurysms, and mm-hmm. that's where the blood vessel is at risk of either rupturing or thrombosing. Patients with venous problems, which tend to be younger patients, patients with blockages in the arteries of the legs, blockages in the artery of the carotids, and development of aneurysms everywhere in the body, particularly outside of the brain or the skull and the heart.
All right, so since you brought up aneurysms, that's a great way to start the show right now. So let's talk about, briefly, because I know we're going to do more of an anatomy in just a few seconds, but what they are and how common they are. You hear about them. I'm not sure how common they are. Can you tell us?
About 14 to 20,000 aneurysms are diagnosed annually and treated. And not all aneurysms need to be treated. The ones that need to be treated are the ones that are more at risk of rupture. Aneurysms are defined with the dilatation of an artery, which is the blood vessel that takes oxygen, which is usually under pressure, that it dilates to more than 50% its normal size. So at certain size in certain arteries, that risk, once it dilates, sort of like a balloon popping. Mm-hmm. So when a balloon pops at a certain size, once that wall gets so thin that the balloon pops, it's sort of the same physics with an artery. At some point, there's a size that the wall is so tight that the next step is for it to rupture.
All right, so as we continue our discussion, I do want to take a moment to let our viewers know that if you have a question for doctors, and the doctor here, of course, you can give us a call, toll-free number, 855-796-4475. Once again, that's 855-796-4475. We would love to hear from you. All right, so the doctor is now next to our 3D image of what is an aneurysm. So doctor, walk us through first the anatomy right there, and then I have a couple questions after.
So this is the descending thoracic aorta. So this is the chest, and here's the abdomen. These are the arteries, the iliac arteries that go to the left and right leg. We have the visceral segment, which are arteries to the guts and to the kidneys. This specific artery we're looking at is in the descending thoracic aorta. So this is a saccular aneurysm. These are actually the highest risk of rupturing. These will rupture at smaller sizes than what we call fusiform aneurysms, mm-hmm. where you see sort of a not so focal dilatation.
When you say saccular aneurysm, you said that's the most dangerous. Does that mean you have seconds, or at that point you're looking at a pretty bad situation?
These develop slowly over time. So not seconds. I mean, you have probably days to weeks to be evaluated and to be treated. I think if you present to the hospital with this specific aneurysm, you'll be treated during that hospitalization.
So they won't even let you leave?
I would say in most cases, no.
Okay, and how do you treat this aneurysm, and why does it develop, if I can ask that? How does it form?
Well, aneurysms, depending on what part of the body they're in, usually develop from some weakening in the wall of the blood vessel. And so there are some advanced histology, which I won't go through now, that where the weakening of the wall and the pressure coming from the heart will cause dilatation of the artery. This one may have started from a small plaque in the aorta where blood leaked into the different layers of the wall, causing some weakening. But they tend to be seen more in males than in females.
Any reason why?
We don't know.
We don't know. Okay.
I know smoking is one of the biggest factors, as is blood pressure. This is one of the few illnesses where you see less frequently in diabetes. So that's interesting. Although diabetics get it, by rate they get it less frequently than non-diabetics.
Does size matter in terms of that size there, in terms of the how big it can get?
Absolutely, size definitely matters, and we were talking about aneurysms. And all different types of aneurysms, size matters. And
what happens next when that occurs? What could happen if it was left untreated?
The biggest risk is, and the highest mortality is from this rupturing into the chest, or an abdominal aortic aneurysm rupturing into the belly. And frequently these grow silently. So they're asymptomatic in many cases. So a patient may not even be aware that this entity is occurring. When it ruptures, you become quickly aware because there's severe pain involved, and the patient can pass out and become, deathly anemic.
And you did mention a few minutes ago, and I did want to ask you, you said that some people can live with aneurysms, and that kind of left me going, wow, is it kind of uncomfortable that a patient know, okay, you have an aneurysm, but you can live with it, don't worry about it? Like, do you have to keep on checking it?
Well, you have to look at your risk factors for having an aneurysm. So family history is probably the #1 risk. If you have a first-degree relative with a history of an aneurysm, you need to consider what age they developed their aneurysm to begin to talk to your doctor about when you should start being looked at. One of the issues is men who smoke. There is a SAVE Act that helps, where Medicare will pay for screening, but in many cases insurances won't screen for this because it's expensive to screen, but it's not as common as, for example, prostate cancer or some other illnesses. But nonetheless, one of the challenges as vascular surgeons face is trying to find a way to screen more patients to find these.
I know, because it's quite scary that you don't even know you may have one.
Correct.
And people are walking around, and who knows if they have one at this point.
Correct.
All right, we have some tests that might be used to determine if you have an aneurysm. Let's walk through these, doctors, if we can. CT scan, MRI, MRA, echocardiogram, ultrasound examination. Do you use them all, or do you have a go-to?
For abdominal aneurysms, we begin with ultrasound examination. It's the best screening exam because it doesn't involve any radiation and it has almost no bioeffects to the body. CT scan is a way that aneurysms are frequently found coincidentally, looking for something else that an aneurysm is found. CT scan is not a good screening tool because it involves radiation. Okay. So if we radiated an entire population, that can have its own side effects. MRI are not good screening tests. And again, when those are performed, usually we find an aneurysm coincidentally. And echo is, when it's done for other reasons, can identify a thoracic aneurysm in the chest. Okay.
And aneurysms, can they be found anywhere in the body, doctor?
Sure. Aneurysms can be anywhere the arteries occur.
Okay.
The brain, which neurosurgery and neuroradiology would tend to treat, but in the chest, the abdomen, legs, upper extremities. Now, different locations are more or less common than others.
Okay, you mentioned a couple of risk factors that I want to go through to show our viewers. What are some risk factors? He mentioned one of those, which was smoking. Gender, you obviously told us that males are more prevalent than women. Age?
Yes.
Really? Old, young? Which age?
Older.
Older.
Over 65 is when you begin screening in males. But again, if you have a relative, a father, an older brother, a grandfather who passed away at 50, you should probably be screened at a younger than 50 age.
All right. High blood pressure. Obviously, if your blood pressure is high, if you have it controlled, are you okay then?
It is much better to have it controlled. The higher the blood pressure, the higher the risk of aneurysm growing over time, the higher the risk of it rupturing.
But just because you have a genetic disposition, does it mean that you are more prone to have aneurysms?
People with high blood pressure are more prone than people without high blood pressure.
Okay.
But it's multifactorial. And to be honest, precisely why aneurysms occur, we don't fully know. There's been a lot of science looking to try to identify, but there's no singular cause.
Okay. Medical history?
Medical history, absolutely. So, the family history is part of the medical history. Other illnesses, exposure to any drugs that might, like steroids that might weaken the body, can put you at risk. Certain genetic syndromes definitely put you at increased risk of having aneurysms.
All right. And the last one, genetics, obviously you can't pick your parents,
Correct.
That's important to know if they had one.
Yeah.
Okay.
The good news about aneurysms, if it's detected early, the vast majority can be treated with great success.
Fantastic. Not like before, that you heard aneurysms and you heard that lots of people passed because of them, right?
Correct. I love talking about Albert Einstein, probably the most famous person who died of an aneurysm.
That's right.
Yeah, he was treated for an aneurysm before the current treatment options were available.
Where did he have it?
He had an abdominal aortic aneurysm, and it was treated in New York by an old-fashioned operation, which we don't do anymore. It was wrapped with cellophane. Cellophane was, researched back in World War II, and it was used to waterproof a lot of things. So a famous Dr. Nissen, who's famous for an operation in general surgery, wrapped the aneurysm with cellophane. And Albert Einstein lived for another 5 years until it ruptured again, or until it ruptured, and he passed away in New York.
A little bit of Trivial Pursuit for us today.
Yeah.
Appreciate that.
That's right.
Just quickly, doctor, how do doctors screen for aneurysms? What is the screening process like?
Abdominal aortic aneurysm, the vast majority are done by ultrasound. Okay. So usually, actually, before that, physical examination is probably most important. But primary care physicians should be feeling the abdomen, not only to see if you have a enlarged liver or you have tenderness, but to try to see if they fill your abdominal aorta. In a thin male, a normal aorta can be palpated, but most of the time in bigger folks, if you feel the aorta, you need to at least think about them having an aneurysm.
All right, great stuff. We're going to take a quick break. Up next, we're going to go over different aneurysms, the most common and the most risky. That's all coming up on the Health Channel. All Health, all the time on South Florida PBS. If you have a question for the doctor, please give us a call. He is right here waiting for any concerns. Dr. Pereda, 855-796-4475. Remember, you can take the Health Channel wherever you go by visiting our website, allhealthtv.com. You can watch the Health Channel live stream or check out videos from previous episodes. We'll be right back.
This is my kind of happy hour.
This is my kind of fast lane.
This is my kind of personal trainer.
My kind of joyride.
My kind of nightlife. Whether you're just finding your stride or making the golden years look good, Florida Blue goes beyond health insurance, investing in the health and communities of all Floridians. So you can feel good saying, that's my kind of blue.
This is my kind of blue.
This is my kind of blue.
This is my kind of blue.
Us. It's what this country is made of. But right now, our bond is framed. How do we get back to us? The Y fills the gaps and bridges our divides. Support your local Y today. Because where there's a Y, there's an us.
Welcome to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with me is Dr. Juan Pereda, a vascular surgeon at the Miami Cardiac and Vascular Institute. If you have a question for Dr. Pereda, give us a call. The toll-free number is right there, 855-796-4475. So different aneurysms cause different risks, which we talked about a little bit. Depending on the size and location of the aneurysm, of course, a doctor may choose to monitor it or maybe schedule a procedure, like we just learned a couple minutes ago. So to get a better understanding of the different types, we have a list of a few. And doctor, I just want to take these one by one if that's okay with you. Let's start with the first one, obviously, abdominal aortic aneurysm. That's the one we were talking about earlier.
So abdominal aortic aneurysm generally should be treated when you're talking about aneurysm over 5.5 centimeters. There are some, that's pretty big.
That's big.
That's 2.5 inches.
Yeah, that's a lot.
A normal aorta is probably 20 millimeters, so less than an inch. So it's more than twice, 2.5 times the normal size when you would consider repairing it. At that size, the risk of rupture starts to skyrocket. So 5.5 versus 6 versus 6.5, 6.5, above 6, we start thinking somewhat of an emergency.
Right.
And the biggest risk is that they rupture. Those aneurysms can have other complications where they embolize down to the legs and you can lose toes and legs, but by and large, rupture is the biggest risk.
Are there symptoms for an abdominal aortic aneurysm?
No, typically they're silent. When they begin to have symptoms, we consider that
rupture?
an urgency.
Okay.
Yeah, I mean, that's an indication to treat, even at a smaller size.
Okay.
So if we have a 4-centimeter aneurysm, but a patient has abdominal discomfort related to the aneurysm, I think doctors need to seriously consider treatment.
All right, thoracic aortic aneurysms, how are they different from the first one?
By location. Okay. And the treatment options are a little different, but they're also silent. We have, because the thoracic aorta is a little bit larger, we have a little higher threshold before we treat them.
Peripheral aneurysms? So
peripheral aneurysms tend not to rupture, or we don't worry about them rupturing and a person bleeding to death. We tend to concern that because of the normal flow in the aneurysm, that they'll clot off or send clot further down part of a body, resulting in losing a limb. So the anatomy of them developing, or excuse me, the physiology of the developing is similar. The consequences are different, so the indications for treating them are different.
And the last one was cerebral aneurysms. Just hearing cerebral, which is obviously, our head, I tend to think, this is just because I don't know anything here, but that's the most dangerous because of the location, right or wrong?
I think being brain dead versus being dead, they're both pretty terrible situations to be in.
This is true. Okay, this is true. You got me there.
Yeah, the indications for Berry aneurysms is really outside of my specialty, which is more within neurology, neuroradiology, and neurosurgery. But there is a lot of the biology is similar, so screening for both is something to be considered.
When one of these ruptures, is there one that's more dangerous than all of them, or are they all basically on the same playing field?
Well, the Berry aneurysms, because they're involved in smaller blood vessels, don't have to be very big before they can rupture and lead to a stroke.
And what's the relationship between these types of aneurysms and, let's say, blood clots?
Well, blood clot is occlusion of a blood vessel, and that's where blood is coagulated. And you see blood turn into this gelatinous, jelly-like, dark thing. If you pull the blood, you may see blood clot on a table, if you ever had the opportunity to see that. But that is an occlusion of a blood vessel. An aneurysm is dilatation, which can lead to a thrombosis or a clot, but it's different, all within vascular surgery, but the problem is different.
But still dangerous as well.
Equally dangerous.
Equally dangerous, that's what I thought. Okay, I want to take a moment to remind our viewers, if you have a question for Dr. Pereda, give us a call, 855-796-4475. The doctor is standing by, and we would love to hear from you. Are all aneurysms serious medical conditions? Because we talked about earlier how some of them you can actually live with, and you probably just monitor them, but is it still considered serious?
It depends on the size. You know, small abdominal aortic aneurysms can be followed, and I've followed patients for over 10 years with no indication to treat them. 20 years from now, they may need to be treated. 10 years from now, it's hard. So it does need to be monitored. But there are many people that will pass from other causes, because these do tend to happen in elderly people. So they're at risk of cancer and coronary artery disease and other things. And then aneurysms that have been fixed, you know, going back to show business, James Garner, and was it George C. Scott? Joe DiMaggio, pardon me.
Joe DiMaggio.
Joe DiMaggio had an aneurysm as well, if you're a Yankee fan, and he had his aneurysm repaired, and he ended up dying of lung cancer, not of his aneurysm.
That's right. And I remember him even talking about it, and there are many people that survive it, don't they?
Correct. After surgery, after either endovascular or open repair, many patients will survive, and their life won't be shortened by the aneurysm.
We talked about these four, and I just want to go back to them: abdominal, thoracic, peripheral, and cerebral. Are the symptoms the same for all four of these when they rupture, or is it different?
Based on the location.
Correct.
So, you know, a severe headache from a cerebral aneurysm that's leaking, chest pain or upper back pain from a thoracic aneurysm that is symptomatic, or abdominal pain from an abdominal aortic aneurysm. And some pain in the legs may be a sign of a lower extremity aneurysm.
Are there types of treatment that are used?
Absolutely. So traditional was open surgery, which is still around and will always be around for certain patients. And depending on the anatomy of the location of the aneurysm, we can treat them with modern techniques. There's the endovascular treatment, which was first around the 1990s and now is in his third, fourth generation and very advanced. So we can treat a lot more people with endovascular means. Nonetheless, there's some people who ultimately are better off treated with open surgery.
All right, and we're going to talk about that more in our next segment, so stay tuned for that. I was wondering, doctor, if someone has an aneurysm, are they more likely to have another one again, and do they live with that fear?
There can be an aneurysm that is confluent with the aneurysm that you had, sort of, the artery next door, so to speak. And there is a relationship to having abdominal aneurysms and leg aneurysms, or a chest aneurysm and abdominal aneurysm. So, yeah, I mean, I consider the aorta one organ. And so the chest and the abdominal aorta need to be looked at once you have one or the other aorta is identified to have an aneurysm. And the lower extremities should also be looked at. And they can be done even just simply with physical examination.
All right. And if an aneurysm is not treated, besides obviously death, which is a horrific result, are there other complications that can occur before that, and that not being the end result?
Well, there can be a mass effect from very large aneurysms. We see, on occasion, huge aneurysms that don't rupture. We can't predict that, but I've seen aneurysms that cause a mass effect where just because they're so large in the abdomen, people will have inability to get their food through, inability to, could have some compression on different organs. But, if they leak, they can be inflammatory aneurysms, or they can get infected. Those are more rare things that can occur. By and large, the concern with aneurysms is that you don't oftentimes know that it's there.
And the fact that you don't know that it's there, is it just the rupture that makes most people realize what happened? Is that why that signal goes off? Or do people detect it in other ways? Because it's quite frightening, again. Sure. You don't know it's there. I could be walking with one for all I know right now. Is it the rupture that's just the alarm?
Nowadays, with our healthcare system, there's a lot of opportunities for patients to have a CT scan, or, this is an elderly patient, or an echo, where these aneurysms are found coincidentally and looking for something else. You present with a kidney stone, and then you have a CT scan and they identify an aneurysm. We do have the occasional rupture of people that show up without ever having identified. That's much rarer now in the 2019 than it was 20, 30 years ago, even 15 years ago. But that does happen on occasion. By and large, people seem nowadays to have them identified coincidentally in testing for some other reason, because they do occur in elderly people, which tend to have evaluations for other reasons.
And that's what happened to a family member of mine. They were getting treated for something, and they by chance found that they had an aneurysm, and that was just by the grace of God.
Correct.
So that was very lucky. And I remember once I was having severe headaches, and I think it was stress, and they did a CT scan on my brain, and my father was like, well, maybe you have an aneurysm, and I looked at him like, are you serious? Yeah. Everything turned out well, but again, it's just concerns that you have because we really don't know.
Sure. Mike, I have another concern when I see this in my practice with patients who have been identified with a small aneurysm, and either through lack of follow-up or for different reasons, will go several years without being looked at again. And then now you're talking about a dangerous aneurysm is about to rupture. And so, somebody dropped the ball and fingers can be pointed, and each situation is different. But that's always, to me, a huge concern when I identify a patient who knew they had an aneurysm years ago and sort of was ignored for either the patient's doing, their possibly their primary care doctor or other physician that just didn't, follow up on it.
That's not good.
No.
All right, thank you, doctor. We're going to take a quick break, and when we come back, the way aneurysms are treated continue to evolve. Dr. Pereda talks about the latest treatments and outcomes. When we come back, you're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for Dr. Pereda, give us a call. Any concern you may have, 855-796-4475. Also, remember, you can take the Health Channel wherever you go, 24/7 by visiting our website, allhealthtv.com. You can watch a live stream of the show and watch previous episodes as well. We're back in 2 minutes.
Worried about keeping your brain sharp as you age? Studies show that these 4 steps may help. Stay physically active. Strive for 2.5 hours of moderate exercise weekly. Reduce vascular risk factors like high blood pressure and cholesterol with good diet, adequate sleep, and medication when necessary. Talk to your doctor about diseases and drugs that may impair brain function, and keep your brain lively with social and intellectual pursuits. For more information, visit dana.org.
This is My Kind of Happy Hour.
My kind of joyride.
My kind of nightlife.
Whether you're just finding your stride or making the golden years look good, Florida Blue goes beyond health insurance, investing in the health and communities of all Floridians, so you can feel good saying, that's my kind of blue.
This is my kind of blue.
This is my kind of blue.
This is my kind of blue.
Many websites selling medication may look professional and legitimate, but the vast majority of sites selling prescription drugs are doing so illegally. Criminals use websites to sell counterfeit medications that may contain life-threatening toxins. Dot Pharmacy is a website verification program that helps you identify safe and trustworthy online pharmacies. Purchasing medicine online can be safe and easy. Just look for pharmacy to the right of the dot in website addresses.
Hi, I'm Janelle Hale, founder and CEO of the National Breast Cancer Foundation. No one should face breast cancer alone. When I was diagnosed 36 years ago, there was no internet, and I had to make a decision with little information. Early detection saved my life. It could save yours too. To learn what every woman needs to know about breast cancer, visit nbcf.org/hope.
C stands for cutting-edge research, clinical trials, and collaboration. Creating breakthrough treatments as Florida's only member of the Memorial Sloan Kettering Cancer Alliance. At Miami Cancer Institute, C also stands for Cure. World-class cancer care right here at home. Learn more at miamicancerinstitute.com.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with me is Dr. Juan Pereda, a vascular surgeon at the Miami Cardiac and Vascular Institute. If you have a health question for the doctor, give us a call. Toll-free number, 855-796-4475. So on today's Staying Healthy show, we're talking about aneurysms, how to know your risk, and what treatments are available. We're just getting into treatments, so while today's options have certainly evolved, I know we talked a little bit about the history of vascular surgery, but do you have anything else to add? I just love it because my dad's 83 years old, so he's a lot older than you.
Sure.
So things have evolved a lot. But I mean, the history from today, it's amazing.
Sure. Well, I think if you go all the way back to centuries ago, when the Egyptians have hieroglyphics talking about aneurysms. And
really?
And talk about aneurysms only being repairable by magic. They were very challenging, and really there was no decent treatment until the late 1800s, where the only option was ligating and dividing the aneurysm, which had many issues with lack of circulation and complications related to that operation, which is not done anymore. And so in the early 50s, Dr. DeBakey and others, you mentioned your father had trained,
yes.
Began to implant homografts, so aortas from people who had deceased to repair the aorta. And so open surgery from 1950 to about 1990 was the only option. So for 40 years, that was the main and only option. In the 90s, back in Argentina, Dr. Juan Pereda did the first endovascular aortic aneurysm repair, which was done in 1992 in the United States at the Albert Einstein College of Medicine.
Look
with
at
Albert
that.
Einstein's history.
That's right, where he passed from one.
Correct.
That's
and
interesting.
So that was performed by Mike Marin, who trained my mentor during my fellowship. To the modern age, where we have a lot of devices. There are physician-modified devices for complicated branched and fenestrated, to now manufacturers are developing devices which you can take off the shelf, even for complicated aneurysms.
Great stuff. I could talk about this all day long.
Me too.
Okay, so when you're talking about aneurysm treatments, are you repairing or replacing the damaged artery?
That's a great question. So in the traditional open surgery, nowadays we're replacing the diseased artery with a new fabricated artery.
Really?
Yeah. So Dacron, which is a type of polyester, is used to repair the aorta in traditional open surgery. And in the vascular methods, you're basically relining the aneurysm, so you're excluding the abnormal part of the aneurysm. So if I mind, this graphic I think sort of shows exactly what's going on, where you have an aneurysm in the abdominal aorta.
And that's a big one.
That's a big one. So the old-fashioned would be basically cut, clamp, and sew, or clamp, cut, and sew. But here you deliver a device to reline. So this aneurysm is still here, but there's not pressure being felt by the walls of the aneurysm, and therefore reducing the risk of rupturing.
Oh, that's fantastic. Yeah. I know we have some more props, but I want to show our viewers some B-roll that we have of an endovascular aneurysm repair. I love this. This is too cool. All right, walk me through this, doctor, and tell me what we're looking at. I think this is about a minute long, so just do a play-by-play like in football.
Sure. This is abdominal aortic aneurysm getting access from the groin, so little small incisions in the groin, percutaneous, where there even needle holes can be achieved. They're delivering the device here. The location is important, that there's a good anatomy of normal aorta above and below. So you want the aneurysm to settle, the repair to settle on a normal artery and not an abnormal artery. And so you can see they're putting the pant legs in now and delivering that into each of the common iliac arteries, relining and excluding the aneurysm. So the aneurysm is still in its location, but now the blood, the pressurized blood, is not being felt by that abnormal part of the aorta.
My goodness gracious. I mean, the way we're looking at it, I mean, it looks like such a big artery, but do you know how small and thin that is? I mean, just for you to get in there, That's just amazing.
That's right. I mean, you can deliver those devices through a hole the size of a typical pen. So, you know, the old-fashioned surgery is a stem to stern incision. These operations, people go home the next day.
That's just crazy, amazing, crazy good. What's the procedure like for the patient? Recovery like? How long does it take you to do that?
So the open surgery is traditionally, 3 to 7 days in the hospital.
Okay.
A lot of risk associated with the anesthesia because it's a longer operation. You're moving around bowel and dissecting through many things. The endovascular approach can be done generally through tiny incisions in the groin, the size of half a centimeter, and that can be delivered to patients. Essentially, doesn't feel what's going on. It can be done with just even some local anesthesia and some sedation. So the recovery from that is a lot better, and those patients can get up and walk around within a few hours after surgery, and monitored for one night in the hospital. But typically, you're feeling fantastic the next day.
That's amazing. I'm going to show our viewers these props in just a second. Just want to put the phone number real quick in case you have a question. Give us a call. Dr. Pereda's right here. Any concern, 855-796-4475. That's 855-796-4475. All right, so we went over that one. Show me what this is and how it works.
So this is one of the devices. You can see all the different devices on the table that are from the different manufacturers. There's several device companies now who work on different, that have different, modifications to fixing the aneurysm, and different advantages, different profiles depending on the anatomy that you want to treat.
Do me a favor, give me the red one, give me the red artery because it's in the way so our viewers can, there we go, so we can see it perfectly. Okay, so tell me what you inserted and what you're doing.
So this is the main body. This is particularly a AFX device, and all the devices are different and have sort of different important facets to the conducting the operation. But I think this model kind of shows you how we have the device packaged in this little, it's compressed within this thing's about the size of a pen. And then as we unsheath it here, you'll see that the stents open up right where we want the aneurysm to fix, and we keep moving down, similar to what we saw in the movie. So, and then we build it down from there.
My goodness. Okay, so when you put that stent in, it obviously stays there.
Correct.
Okay, and does that stay with you forever? Do you have to do any repairs after that?
If everything goes well, it stays there
forever. If everything goes well, right? Okay, right.
These do have a small risk of infection, which we would traditionally have to convert to an open surgery.
Okay.
But that's a rare entity. But this graft is designed to last you your lifetime. And so there are interventions that need to be done sometimes when certain types of things called endoleaks occur, where the aneurysm is not completely excluded, and that's where your vascular surgeon or vascular specialist will have to come back in and maybe do another intervention. So important thing for your vascular surgeon or specialist to identify is, are you the right candidate for the endovascular repair versus the open repair?
Who's the right candidate then for that?
Well, I think by and large, people that are anatomically suitable for endovascular repair and today are repaired with an endovascular approach. But we could build this up depending on how the aneurysm could extend up above these renal arteries, and so there are branched endografts and fenestrated endografts which you can use to reline this. As things get more and more complicated, you need to evaluate which is going to be more durable, either the open repair or the endovascular repair.
And once again, once you put that stent in, that enabled the artery to
be relined. Wow. And you'll see these aneurysms shrink, and when the aneurysm is fixed correctly, you'll oftentimes see the aneurysm shrink.
I was going to ask you then, what happens to the aneurysm? Because obviously it's still there,
sure,
but then it starts...
The body will remodel, and then the aneurysm will start to shrink slowly, but you will see, and when you see aneurysm shrinking, as a vascular surgeon, you're pretty comfortable that aneurysm has been successfully repaired.
And again, I have to reiterate, I mean, this is a big motto, but I'm just thinking of that tiny, thin artery and how you get in there.
Sure.
And meticulously, I'm assuming. It's mind-boggling.
Yeah, well, part of the indication for the surgery is how do you get there?
All right.
If there's any disease in the arteries below, that will modify your approach.
How do you determine someone's risk for this kind of surgery? If there is any, for that matter.
Sure. Well, I mean, they have a normal cardiac risk assessment before surgery. and involves how their kidney function is, what their risk for anesthesia is, how their lungs are functioning, and if for patients, this is done to prevent rupture. So people who have small aneurysms and are diagnosed with some other morbidity that is more serious than this, in some cases, cancer is the first example that comes to my head.
Right.
You may or may not even, attend to this.
Okay. By the way, if someone isn't a good candidate, since we're talking about that for endovascular aneurysm repair, there are other options I want to go through, doctor, if that's okay.
Sure.
There's endovascular aneurysm repair, of course. Open, what's that?
Open is traditional surgery,
okay,
where big incision is made. Hybrid is basically a combination of traditional surgery with endovascular approach. So that is done in more complex aneurysms where we'll do a debranching to improve our landing zones.
Okay.
Landing zone is where the stent is landing. So in between, we're not so worried about, but the attachment proximally and the attachment distally is what kind of determines your suitability.
Okay.
And the complex endovascular repairs are the sort of modern techniques I'm talking about, which fancy words like parallel stent grafting and branched endografts, fenestrated endografts, which we do employ here at MCVI.
I have a couple more questions, but I did want to ask, are there any of those props that you want to go through real quick for us?
So these large ones are actually thoracic aneurysm grafts from different manufacturers.
Okay.
This is an upside down graft, but this is another example of a stent graft, different manufacturer. And you can see the ones on the table, again, are just different device companies that have developed, different profiles that, depending on your anatomy, some stent graft may be more suitable than the other.
Of all these, which one is the one that you use more prevalent?
Well, I don't want to, there's interchangeable, and, I don't want to sort of have any bias as to treatment. If there's suitable for different devices, I really try to pick it based on the patient's anatomy and not based on device company.
That's a great answer, because one size does not fit all.
Correct.
Right?
That's right.
We've come a long way. We talked about the history of where we are, where we were from Einstein to today. I'm just wondering now, just out of curiosity, since we're in 2019, where is this going? How is this evolving in the future? Do you know? Is there more research being done, more fascinating stuff coming?
Absolutely. I mean, there's GPS guidance for trying to use less radiation, trying to less contrast delivery to the patients, because these contrast can damage the kidneys, and typically we need contrast for these treatments. So people who have poor kidney function can be at risk of more kidney damage during this procedure. So using different types of modalities to enhance the imaging, to have less side effects or consequences from the procedure, and also to expand the indications for treating aneurysms that do involve these side branches. Either in the thoracic case or in the abdominal case, and the treatment of dissections, which is not really a topic of this, which is a tear in the artery, which can lead to an aneurysm.
Ooh, all right.
Yeah.
You must have some steady hands.
Well, I try.
I'm sure you do. I would think. All right. Well, I'm really fascinated by this. This has been one of the coolest things I've seen so far on this show. All right. When we come back, up next, we're going to talk about what life is like after aneurysm surgery and go over some important prevention tips as well that you should know about. You're watching the Health Channel. All health, all the time. Education. I mean, can you get any more than this on South Florida PBS? If you have a question, please, who needs YouTube when you've got the Health Channel, right?
That's right.
Who needs to go to Google anymore? Just join us on the Health Channel. Toll-free number, 855-796-4475. Remember, you can take the Health Channel wherever you go by visiting our website, allhealthtv.com, because it's all about you. We'll be right back.
I may look like all the other dogs, but I was born for a purpose, to one day be your companion, your eyes to see the world. I'll be your courage, your friend. With me, you'll find new freedom and hope for a better future. A dog I'm not. I'm a Southeastern guide dog.
This is My Kind of Happy Hour.
This
This is my kind of fast lane.
This is my kind of personal trainer.
My kind of joyride.
My kind of nightlife.
Whether you're just finding your stride or making the golden years look good, Florida Blue goes beyond health insurance, investing in the health and communities of all Floridians. So you can feel good saying, that's my kind of blue.
This is my kind of blue.
This is my kind of blue.
This is my kind of blue.
Thanks, Coach. Thanks for teaching me about teamwork and leadership.
Thanks for showing me that sports help me stay healthy and do well in school. And thank you for teaching me about concussion.
Letting me know that I should tell you if I think I have a concussion. And how to protect my head and brain. Because one day, I want to be a teacher, an astronaut, scientist, or a coach, just like you. Thank you for protecting my future.
SCAD stands for spontaneous coronary artery dissection, and it means there's a tearing in the walls of the arteries that bring blood to the heart muscle. In recent studies, it seems to affect more than 90% women compared to men. It's a disease that is not well known, but the causes can include certain types of artery problems such as fibromuscular dysplasia and other connective tissue disorders, as well as being peri or postpartum, and then other things such as emotional stress or extreme physical exertion. The main signs and symptoms are presenting with a heart attack, and those signs are chest pain, trouble breathing, any type of discomfort in the chest. People may feel lightheaded or dizzy or sweaty, and if you happen to have a predisposing disease of the blood vessels, then definitely have a low threshold to getting help.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with me is Dr. Juan Pereda, a vascular surgeon at the Miami Cardiac and Vascular Institute. I want to remind our viewers, if you have a question for Dr. Pereda, there's the phone number right there, 855-796-4475. So aneurysms are important to detect and manage sooner than later, making prevention all the more important. So doctor, how much can lifestyle modifications impact someone's risk for an aneurysm?
Smoking is by far the number one impactful lifestyle modification.
We have actually a graphic, and that was the number one, so I'm not surprised you hit it on the money there. So let's show our viewers, and there it is right there. Don't use tobacco. I don't think there's one segment that we don't do here on the Health Channel where that's the biggest no-no. Sure. The second one, doctor.
Particularly in aneurysms, we're not clear on other modifications that can be made besides smoking and controlling your blood pressure. Healthy diet and managing cholesterol, exercise are good things just for overall heart health. Specifically with aneurysms, tobacco's a biggie, and blood pressure control is probably another thing that can modify and have some impact on aneurysms.
Can you explain to me, I want to go back to the tobacco, what the impact is on the tobacco, the smoking with an aneurysm? Where's the correlation there?
Well, at some point, tobacco causes inflammation, and the inflammation in the artery and the aorta can lead to weakening of the wall. And that weakening is sort of what initiates, once that wall is a little bit weakened, as pressure goes on and you age as days go by, that pressure can inflate the balloon, so to speak. And how do blood pressure and cholesterol also relate to that aneurysm? What do they do? Well, blood pressure is specifically that. You know, as the blood pressure is up, it's sort of like going back to the analogy of inflating a balloon. It's always hardest to get that initial part of the balloon inflated, but once you get the balloon a little bit inflated, it's easier to keep getting it to grow. So the pressure it takes to get that past that initial part, if we can keep that pressure down, you can avoid the aneurysm altogether. Cholesterol is not a clear correlation. It's believed that but it's I guess more related to having a risk of aneurysms, but I'm not sure that the statins have been proven to decrease aneurysm formation.
All right, we just have a few minutes left. I just want to tell our viewers again, if you want to give the doctor a quick call, Dr. Pereda, there it is, 855-796-4475. Once again, that's 855-796-4475. I know we talked about it just a little bit, but while serious aneurysms can certainly be managed, we have two well-known examples. We kind of mentioned them a little bit, but I do want to show their pictures because two great men, Joe DiMaggio, I mean, there just aren't any words to describe what an amazing man he is, and with the Joe DiMaggio Hospital that's still around. He died of an aneurysm?
No,
or he had an
Joe DiMaggio and
one.
yeah, they were both, Joe DiMaggio was treated successfully for an aneurysm.
And he lived how much longer after that?
That's, you got me on that one.
Okay, Trivial Pursuit. Next time you're on, I'll find out. James Garner, another fabulous human being.
Yes, I believe he was a victim to his aneurysm. Also famously, Lucille Ball. I Love Lucy.
Really?
Yeah.
Lucy.
Yeah.
Love those two, Ricky Ricardo.
And George C. Scott.
George, wow.
Sure.
Great man. Which one did Lucy have?
Abdominal aortic aneurysm.
And was she a victim to that as well?
She was.
Oh, look at that.
Yeah.
And again, these are things that people don't know about, and it could just happen
Correct.
and rupture. And wow, that's just more important to remember those things. How important is it for people to do lifestyle modifications if they have survived, let's say, an aneurysm? It has been repaired, they went to you, they had surgery. How important is that after?
Well, I think what's important is that you maintain contact with your physician that repaired your aneurysm, because particularly in endovascular repair, monitoring the aneurysm is considered part of the treatment. So after it's been repaired, because we haven't cut out the aneurysm and sewn in a graft, we need to follow that aneurysm, either with ultrasound or with CT scans, to make sure that that aneurysm has been treated successfully and that there aren't secondary procedures or interventions that need to be taken. So, continuing to comply with follow-up is probably the most important lifestyle modification. And clearly, again, back to smoking and back to keeping your blood pressure controlled, those will help have you have a more successful outcome after your treatment.
Because I'm marveled at the fact that, you can have so many complications, but so little symptoms. So as an individual, I ask myself, well, how do I know if I'm at risk for an aneurysm? What can I do to help hopefully prevent that from ever happening to me? And you would say?
I would say avoid tobacco.
Okay.
I would say, standard blood pressure control, and also talk to your family and see if anybody in the family has been aware of anyone with an aneurysm.
Okay, and how do patients get referred to a specialist? And I'm going to drink some water because I'm fighting a cold. My apologies, doctor. How do they get referred to a specialist?
By and large, it's a primary care physician, or in many cases a cardiologist, that identifies that there's an aneurysm, and they will refer to specialists. There are 3 specialties that sort of treat this: vascular surgery and interventional radiology, particularly in different parts of the country, will treat aneurysms. And so most vascular specialists will treat at least simple aneurysms, and as they become more complicated, depends on your the available resources in the community that you're in.
I want you to know it's been just great having you. I know this is the first time you came on the Help Channel, and I'm so grateful. I mean, Dr. Pereda has had 2 surgeries already today. What were those 2 this morning?
They were for venous disease. They were obstruction of veins for lower extremity ulcers.
And to follow that,
mesenteric revascularization for blockage in the celiac and superior mesenteric artery.
Then he comes here to the Health Channel, and he's going to surgery right now for
that operation, for a blockage of blood vessels to the intestines.
Do appreciate your time. I know how busy you are. It's really fantastic. Being with you has also brought me so many memories with my father. So great stuff for me. Any final thoughts for our viewers? Final tips, final anything, takeaway? Yeah,
I think, to have good, to start with your primary care physician and talk to them. Am I at risk for having an aneurysm? Should I be screened? Should I be evaluated? I'm always concerned when I find somebody who had all the risk factors, and there's a lot of potential things that can go on, and your physicians are busy, and sometimes they can unwittingly overlook something. So I think have some buy-in and responsibility from the patient to ask their primary care doctor, am I at risk? Should I be screened?
All right, and if you should be screened, don't play around and get it done.
That's right.
And the last thing I want to hone in on is the fact if you have one, you have to be monitored. Don't let it go.
Yes, absolutely.
That's really important. All right, great stuff
Pretty
today.
important.
It's great having you.
Thank you.
I do want our viewers to know that the doctor is from Los Angeles. So if they know me, and they know me well, We know who he's going for in the Super Bowl. Right, Doctor? Who are you going for?
The Los Angeles Rams.
I hope you come back on our show.
We can still be friends, right?
We are going to be friends, but when you come back, you know what I'm going to tell you, right?
We'll see. We'll see. We'll wear a hat.
He's the GOAT. He's the GOAT. Let's see. We'll put some money on it. Thank you so much for your time. God bless you. Thank you for joining us today. That does it for us this hour. Be sure to join us next time on the Health Channel. All Health All the Time on South Florida PBS. Follow us on Facebook and Twitter using the hashtag AllHealthTV. And please be sure to visit our website, allhealthtv.com, where you can watch the Health Channel live stream. I'm in shock he's going for the Rams. You can watch the Health Channel 24/7, watch videos from previous episodes.
Don't hold it against me.